So let's talk about primary infantile glaucoma, which is one form of congenital glaucoma. So what is the definition of primary infantile glaucoma? When the rise in intraocular pressure occurs within the first 3 years of life, we term it primary infantile glaucoma, and this particular time duration is very important, and the importance will become clear as we proceed with this topic. So in the definition over here, they've said that this is a glaucoma which is secondary to maldevelopment of the anterior chamber angle. So what does maldevelopment mean? It means improper development. And what is the improper development? The improper development is that of the angle, and the angle is composed of the canal of Schlemm and the trabecular network, right? And so primary infantile glaucoma, it basically fulfills the following criteria. The anomaly itself, the anomaly of the angle, is present at birth, because this is maldevelopment. In the definition, we have said that the problem is due to maldevelopment of the angle, and development happens before birth, and so maldevelopment obviously would also happen before birth. So the anomaly itself is present at birth. This is the first criteria. The second criteria is the fact that the IOP elevation occurs during the first year of life. Now there is a bit of a contradiction over here and the line before, but that is because in 90% of cases of primary infantile glaucoma, the IOP elevation does in fact happen by the first year. Third point, there is no other anomaly of the eye or the adnexa, because we've called it a primary condition, and primary conditions of the eye are not accompanied by other anomalies of the eye or associated structures. So I'm hoping these basic concepts are clear to you. I will repeat it. Primary infantile glaucoma is a type of congenital glaucoma in which the rise in IOP happens within the first 3 years of life. And this is important because during the first 3 years of life, the eyeball is still growing and therefore is capable of change. Again, I will explain this later. Second point is that the pathogenesis is basically maldevelopment, which happens during the fetal period, the embryonic period. Maldevelopment of what specifically? The angle, which is composed of the trabecular meshwork as well as the angle of Schlemm. Additionally, because this has been described as a primary condition, no other associated anomaly is found. Among other important tidbits includes the fact that this makes up 50% of pediatric glaucoma. Family history is not that significant. So again, in a lot of stuff it is significant, but not over here. It is a bilateral condition in majority cases. Again, in cases of primary infantile glaucoma, at the time of birth, 40% of the patients will already have raised IOP, and by first year of life, 90% will have developed it. Again, etiology, the same thing has been mentioned again, that there is a development, that the pathogenesis underlying primary infantile glaucoma is a developmental defect of the angle. But there can be different types of defect. For example, there can be maldevelopment of the trabecular meshwork, or there might be a maldevelopment of the canal of Schlemm, or there might be an extra membrane, the Barkin's membrane, present in front of the trabeculum. Again, remember this name for MCQs. Or maybe there might be an anterior insertion of the iris and the ciliary body that would block access to the trabecular meshwork. What about the symptoms? There are 3 cardinal symptoms which are likely to be mentioned in a scenario: lacrimation, which is watering of the eye; photophobia, sensitivity to light; and blepharospasm, in which the eyelid is tightly shut because of the photophobia. So the mother will basically come to you with an infant and say that the infant's eye is always watering, and the infant is not able to look directly into light, and that the infant keeps the eyes tightly shut for a prolonged period. So another important buzz phrase which you must always associate with primary infantile glaucoma is corneal haze, and that will make sense later when we will talk about some details of pathogenesis. Always associate corneal haze slash corneal cloudiness. Okay? And the third important thing is ophthalmos, enlarged eyeball. A child with primary infantile glaucoma will have an enlarged eyeball known as ophthalmos. In addition to the obviously enlarged eyeball, the patient will present with the signs and symptoms of lacrimation, watering of the eye, photophobia, and blepharospasm, meaning the infant will keep the eyes tightly shut because of the photophobia. Additionally, on examination using a torchlight, the ophthalmologist will be able to appreciate that the cornea is hazy. So these are very important. So normally when we talk about adult glaucoma, we don't mention enlarged eyeball. And the reason for that is that within the first 3 years of life, the eyeball is still flexible. So during this period, if glaucoma develops, meaning if during this period there is elevation of IOP as is seen in primary infantile glaucoma, that can lead to increase in size of the eyeball, a feature which will not be seen in adult glaucoma. Alright, so these are very important points. In the case of science, obviously the IOP will be raised, and when the corneal diameter is measured, that would also be raised. Why is there corneal haziness? It is because the increased IOP will cause a break in the most posterior layer of the cornea known as the Descemet's membrane, and this break of Descemet membrane will disrupt the endothelium, which normally maintains the hydration level of the stroma. So with the break in the Descemet membrane and the subsequent endothelial decompensation, there will be overhydration of the stroma, leading to a very characteristic corneal edema visible as corneal haziness or corneal cloudiness. Important feature which can be observed on slit lamp examination are hapstria, which is again a buzzword you should associate with glaucoma, and these are basically the healed breaks in the Descemet membrane. A couple of other important things include subluxation of the lens because of the damage to the zonules. A very important point is the fact that because of the ophthalmos, the increase in size of the eyeball, there will be development of myopia. Myopia, if you remember from physiology, is because of two facts. Either there is a problem with the lens, or the size of the eyeball is too large. So the ophthalmos, which develops in primary infantile glaucoma, leads to axial myopia, and this is something they can ask in an MCQ. So when the examination is done, using just torchlight, corneal haziness will be appreciated. Ophthalmos will be quite appreciable with the naked eye, and on slit lamp examination, hapstria will be seen, and if gonioscopy is performed, it will be seen that the angle structures are anomalous, and if when ophthalmoscopy is done, there will be the normal findings of glaucoma, including cupping. So there is loss of visual acuity associated because the increase in IOP will damage the optic nerve, and also because the corneal clouding will also contribute. Astigmatism can develop because of the change in the shape, and myopia will develop secondary to ophthalmos, and subluxation can also contribute to the loss of visual acuity. So how do you diagnose a case of primary infantile glaucoma? Based on the raised IOP, which will be appreciated using a tonometer, based on enlargement of the corneal diameter, which can be observed on slit lamp, etc., based on the gonioscopic findings, which will be able to through which we will be able to see the maldevelopment, and also fundoscopy will show the usual changes. As far as medical therapy is concerned, it is limited value, it is only temporarily effective. Myotics are not used because the problem is maldevelopment of the system, and increase in outflow cannot be achieved. Prostaglandins, beta blockers, etc. can be used. The most important or the most helpful surgery is goniotomy, but it can only be performed when the cornea is clear, and in most cases the cornea does become hazy in cases of primary infantile glaucoma. So in this case you make an incision, okay, in the angle. If this goniotomy is not possible, you go for trabeculotomy, in which a part of the trabecular meshwork is removed, and if this is not successful, then trabeculectomy is performed, in which direct drainage into subconjunctival space is done. In addition, artificial drainage shunts can be placed and laser therapy can be done. And in laser therapy, via use of diode laser cycloablation, the ciliary processes can be damaged to decrease the aqueous humor production.